Hi, I hope you all can hear me. Can you all hear me?
Yes, we can.
Okay, hi. So good evening, everyone. I'm Dr. Kala Shanmugasundaram. Thank you for joining this month's CME program organized by the Medical Education and CPD Committee of the College of General Practitioners of Sri Lanka. This evening's session, Low Back Pain, How Do I Approach It, will be delivered by Dr. Jeyakumar Janaarthanan. Dr. Janaarthanan is a board-certified consultant orthopedic surgeon working at the Neurotrauma unit at NHSL. He completed his MBBS training at Sri Ramachandra Medical College and Research Institute in Chennai, Tamil Nadu. He subsequently returned to Sri Lanka, where he did his postgraduate training in orthopedic surgery and then went on to be a clinical fellow in trauma and orthopedic surgery at the West Suffolk NHS, UK. He has successfully completed his MD in surgery in Sri Lanka and his MRCS from the UK. He received the Prof. Milroy Paul Gold Medal for clinical surgery at his MD surgery Part 2 exam. He has also presented at All India Spine Society Annual Congress 2025. He has co-authored a publication on Sri Lankan guidelines for management of patients with rectal bleeding. He enjoys reading and playing basketball in his spare time. So without further ado, I'd like to invite Dr. Janaarthanan to start his presentation. And can I please remind everyone to please mute your mics? Thank you. Over to you, Dr. Jana. Dr. Jana, are you there? Hi, Dr. Jana, we can't hear you.
Can you hear me now? Can you hear me on the set now?
Yes, we can hear you now and we can see
I'm
you
sorry.
as well on our
Right,
audio.
sorry, there was a technical glitch. I'm sorry for that. Okay, I'll start right away.
No
Sorry.
Thank you.
Good evening, ladies and gentlemen. Firstly, I would like to thank the College of General Practitioners of Sri Lanka for giving me this opportunity. I'm here to talk about lower back pain. How do I approach it? Why? Why is this an important topic? Low back pain is one of the leading causes of disability worldwide. It affects nearly 80% of the population at some point in their life. Proper assessment of low back pain prevents unnecessary imaging, chronicity, and disability, and hence this is very important. What are the learning objectives of this lecture today? I would like everyone to know the anatomy of the spine, to know the etiology of low back pain, to understand the clinical approach to low back pain, a thorough history, and an excellent examination. What would be the necessary investigations be able to differentiate between a mechanical back pain and non-mechanical causes. Review the evidence-based management strategies, the importance of a multidisciplinary team approach, and last but not least, to identify orthopedic emergencies as far as back pain is concerned and to refer them promptly. First, I would start out with the basis of the lumbar spine anatomy. As you are aware, the lumbar spine consists of lumbar vertebrae L1 to L5. Above the lumbar vertebrae is the thoracic 12, and below the L5 is the sacral S1 vertebrae. There is a diagram that you can see on the screen now. There is an intervertebral disc where my cursor is pointing to that connects the bodies of adjacent vertebrae. Similarly, at the back, the facet joints connect the vertebrae posteriorly. The anterior longitudinal ligament is attached all along the spine, anterior to the vertebral body. The posterior longitudinal ligament is attached just behind the body, and it's anterior to the spinal cord. The ligamentum flavum lies posterior to the spinal cord, and the spinal cord is contained in the vertebral canal. There is an intervertebral foramen that is lying to adjacent pedicles where a nerve root will exit. And on the diagram on the right side, you all can see there is the normal cervical lordosis, thoracic kyphosis, lumbar lordosis as well again. This second diagram goes on to show how on flexion, the disc tends to bulge backwards and the facet joints tend to get distracted a bit. Whereas when the lumbar spine is in extension, the disc doesn't bulge so far backwards. My cursor is right now in the intervertebral foramen through which the nerve root exits from the spinal cord. A bulging disc backwards would tend to compress this nerve root, as a result causing significant pain. The disc itself is a phenomenal structure. It's somewhat like a shock absorber. It consists of a nucleus pulposus in the center and an annulus fibrosus that surrounds it and contains it. The disc material, the nucleus pulposus, is well contained until the time when, if a sudden jolt or sudden compressive force or forward flexion can lead to a tear in the annulus fibrosus, leading to the nucleus pulposus being sort of released backwards. This can give rise to a mechanical neuronitis, as you see in this diagram where my cursor is, causing a pinched nerve. Rarely, without much disc material, it's just the chemicals and the cytokine response that this nucleus pulposus elicits that causes a chemical neuronitis due to interleukin-6, tumor necrosis factor, and various other catecholamines that causes a chemical neuronitis also. In a sense, that is, in short, the anatomy of the lumbar spine. One must be aware of the various differential diagnoses of back pain in order to be able to pinpoint a diagnosis. So it's somewhat like Sherlock Holmes. You know the possible set of criminals, then you try to pinpoint who is the culprit in this particular patient. So in thoracic back pain as well as rib pain, it could be due to trauma, it could be due to metastatic disease or infection, thoracic disc herniations, or an osteoporotic fracture. The diagram here on the right side highlights X-ray image of a thoracic spine compression fracture. It's highlighted by an outline diagram on this side. So this wedge compression would reduce the space available for this thoracic nerve root to exit and cause circumferential pain along the chest wall. as well as pain during breathing for this particular patient. Thoracic facet joint arthropathy is also not an uncommon cause of thoracic back pain. Next, we have lower back pain. Muscle strains, thankfully, is the commonest cause. Disc herniations come a close second. Degenerative spondylolisthesis, spinal stenosis, lumbar radiculopathy, lumbar spinal tuberculosis, herpes zoster can all cause low back pain. In herpes zoster, typically, one would find vesicles along the neurotome or the dermatomal distribution of a particular nerve root. You see vesicles, and that pain is excruciating. Once the diagnosis confirmed clinically, acyclovir is the treatment of choice. One should not forget the non-orthopedic causes of mid-back pain, namely an abdominal aortic aneurysm or even an aortic dissection could be a cause for a severe back pain. A renal colic is not uncommon. It's not uncommon for a patient with a severe renal colic to show up at an orthopedic clinic as well. Here in the image, you can see a significantly prolapsed disc pointed by this red arrow that causes significant cord compression. The image on top shows tuberculosis of the spine. Lower down in the spine, the sacrum and coccyx also can give rise to back pain. Sacroiliitis is also one of the common causes of back pain in this region. Sacroiliac joint infections are not uncommon. Sometimes they're tuberculous, sometimes they're bacterial as well. Ankylosing spondylitis also causes significant inflammation of the facet joints as well as the sacroiliac joints. Coccydyna, where one gets an intractable pain from the tip of the coccyx, which could be due to following a trauma or could be insidious in onset. It's not uncommon for me to see a pilonidal abscess in the natal cleft that causes back pain, and a thorough clinical examination will help you to diagnose it. There are certain risk factors for back pain, namely obesity, smoking, female gender, chronic kidney disease, poorly controlled diabetes, work involving heavy manual lifting, vibrating tools, and prolonged sitting. I emphasize these factors because if you have to treat a back pain successfully, all these risk factors, which some of them can be modified, must be modified. Now, what is the epidemiology and the burden of this disease? The Global Burden of Disease Study 2020, low back pain ranks number 1 in years lived with disability. So this is the most important disease causing the maximum disability world over. The highest prevalence is 40 to 80 years of age. The economic impact is in billions because in terms of treatment and loss of productivity as well. Low back pain can be classified depending on the duration. Acute low back pain would be any back pain that is less than 6 weeks in duration. Subacute low back pain would be duration of 6 to 12 weeks. Chronic back pain would be any back pain that is greater than 3 months or 12 weeks. Based on the etiology, mechanical back pain, which is 90% of the cases, thankfully, is usually due to muscle strains, disc herniations, or lumbar spondylosis. Non-mechanical back pain, which is thankfully rare, is mostly due to infections, inflammatory disorders such as rheumatoid arthritis or ankylosing spondylitis, and malignancy, which can either be a metastasis, which is more common in the spine, than a primary malignancy in the spine itself. That brings us to the red flag symptoms and the yellow flag symptoms. Now, what is the importance of taking history? Now, I would like to emphasize this is the single most important thing in clinching a diagnosis as far as low back pain is concerned. It's imperative one must note what the onset of this back pain is. Is it following a trauma? Is it following a violent bout of cough or a sneeze? Is it following a road traffic accident, a whiplash injury? that will necessarily clinch the diagnosis. The duration and the nature of the pain is equally important. For example, a radiating sharp electrical type of pain that radiates from the right buttocks right down the back of the leg onto the lateral aspect of the calf is typical of sciatica, probably due to an L4-5 or L5-S1 disc prolapse, pinching the L4 or L5 nerve root typically. Aggravating and relieving factors equally are important, such as a cough, sneeze, or bending forward. Associated symptoms such as neurological deficit, where one cannot lift your great toe or have got a foot drop, associated fever and weight loss are important things to note as well. A person's occupation is equally important. Somebody who does a lot of manual physical work, bending down, lifting heavy objects, has a higher risk. Equally, somebody who has a sedentary lifestyle, like a banker or a web designer who's always on a chair and sort of slouched forward looking at his laptop, is also at risk. It's important to think of the hip when you think of the back. The general orthopedic dictum is 50% of back pain comes from the hip, 50% of hip pain comes from the back. So it's not uncommon for us to see a case of avascular necrosis being treated for back pain, and then comes to an inoperable stage, and the patient shows up with hip pain. Similarly, sometimes the problem is in the hip joint itself and not in the back. So it's important to ask a few questions about the hip, one's ability to squat and walk and things like that. Always keep in mind non-orthopedic cases as well. As I emphasized earlier, renal colic, aortic aneurysm, dissection, pancreatic tumors, pancreatitis, uterine origin pains, ovarian pain can all mimic low back pain, even dysmenorrhea. Back pain has association with psychosocial assessment, and fear, avoidance, depression are all related with it. What are the red flags and when should one worry? Red flags indicating pathology are a history of significant trauma, which can indicate a fracture risk, unexplained weight loss and fever, which probably indicate a malignancy or infection, such as tuberculosis. Constant night pain, rest pain is indicative of tumor or an inflammatory condition, such as ankylosing spondylitis or rheumatoid arthritis. Saddle anesthesia and bladder dysfunction are typical of cauda equina, which one must always ask and should never miss. History of a past malignancy, it could be a lung malignancy, uterine, it could be an ovarian, all that must be looked into, because for fear of a metastatic deposit in your spine causing a back pain. And please remember, today, if it's a single metastatic deposit, it can be cured if intervention is sought early enough. Urgency of evaluation imaging is based on red flag signs. If somebody has got saddle anesthesia and bladder bowel dysfunction, he needs an urgent MRI, an urgent referral to an orthopedic surgeon. Physical examination, how does one proceed it and what matters? When a patient walks into your clinic, the important thing is gait. There are various different gaits a patient could walk in with. If the patient has got profound severe sciatica, he could have a sciatic scoliosis, or it could be an adolescent scoliosis as well. If the patient has got a foot drop due to a neurological deficit, he walks in with a high stamping gait. A patient with a cervical myelopathy, how they're able to maintain the posture also matters. Somebody with severe canal stenosis is usually crouched forward and bent forward and relieved on bending forward. He's unable to walk straight because then the stenosis is exaggerated. Muscle wasting is there are in chronic cases where you could have waste as well. In proximal stenosis and nerve root compressions, one can have quadriceps and hamstring wasting as well. Palpation, tenderness at the fracture point, tenderness or step sign at the spondylolisthesis is possible on palpation. It's imperative to assess the range of motion of the spine, that is forward flexion and extension. If the patient is not in too much pain. Extension is limited if there is a facet joint pathology. It is imperative that you do a straight leg raise test to see whether the leg can go up to the 90-degree mark. A thorough motor sensory examination of the lower limb, looking for extensor hallucis, flexor hallucis, tibialis anterior, tibialis posterior, as well as quads and hamstring strength must all be documented. Reflexes also must be checked because cord compression can give rise to brisk reflexes or even clonus. Subtle signs of early myelopathy, where one finds it difficult to button his shirt, thread the needle with this thing, or has got clumsiness of grip, should not be missed. The straight leg raise for radiculopathy is a very, very sensitive test with a 91% sensitivity, but it's not specific though. It's important to quickly examine the joints, the hip, knee, and the ankle joint to see if there is any other pathology in them that is preventing you doing any of the spine-related tests. One should not miss the pulses in the leg. In rare instances of a case like Larish syndrome, you could have an aortic bifurcation clot that gives rise to an absent pulse, as well as bladder bowel distension because of lack of spinal blood flow. And the treatment is entirely different. It's a vascular emergency. So as a routine, make sure that you assess the vascular status of both limbs as well, because it could also be a vascular claudication and not necessarily a neurogenic claudication. When to order imaging is the next question. By the time you completed the history and the examination, you should be able to come to a clear-cut diagnosis as to what spinal pathology you're suspecting. The imaging order will depend on your suspicion. Routine imaging is not required for acute back pain as far as the American College of Rheumatology guidelines goes. The indication for imaging is when red flags are present, persistent pain greater than 6 weeks, no improvement on conservative care, if there is progressive neurological deficit. The preferred modalities are, as a general rule, we do an X-ray with a suspected fracture or degenerative condition. We can also do dynamic X-rays in case of spondylolisthesis. I do flexion extension views. In case of scoliosis, we do lateral bending, right and left bending views to see if the scoliosis corrects to a certain extent. MRI is the best for disc pathology, nerve or spinal cord compression, or a suspicions of malignancy. CT scan is best for bony abnormalities, spondylosis, or post-spine surgery, where the implant causes metal artifact dysfraction if you do an MRI. Later modalities such as PET CTs are being done now in patients who have multiple metastases. Now, what is the evidence-based strategies? Obviously, the management depends on the diagnosis, but as a general rule, if it's a mechanical acute low back pain, conservative management is the first option of choice. Education and reassurance of the patient of the self-limiting nature of these cases is the most important thing. Second would be to activity modification. We avoid prolonged rest and avoid bending from the spine and the neck. Non-steroidal anti-inflammatories, acetaminophen, muscle relaxant, and steroids have shown definitive benefits. Physical therapy by a physiotherapist and core strengthening also helps a long way. In chronic low back pain, one might have to use a multimodal approach where exercise therapy shows significant benefit. And do not forget the risk factors I mentioned earlier. All of them have to be controlled if you want your chronic back pain to improve. Cognitive behavioral therapy for psychosocial factors is important, and education of patients, how they go about their day-to-day activities, is equally important. Intervention in pain management can be given via epidural steroid injection, facet joint injections, nerve root blocks as well, which is routinely practiced at our unit, at the Neurotrauma unit, National Hospital. When is surgery indicated? If there is failed conservative therapy of more than 6 months, or if there is a progressive neurological deficit, severe spinal instability or deformity, then there is a role for surgery. Evidence-based procedures are microdiscectomy for herniated discs, spinal fusions for instability or spondylolisthesis, decompression surgery for neurogenic claudication and stenosis, minimally invasive spine surgery, and finally, endoscopic spine surgery is coming of age now. I would like to have a case-based discussion, and if the audience would participate, I would be grateful. If that is possible, you can raise your arm and please, one person at a time. So I want to discuss the diagnosis and management of 3 cases I have brought here. So the first case is a 35-year-old fit, young, acute low back male with acute low back pain after lifting weights. He has no red flag signs, normal straight leg raise, normal neurological exam on both legs. Duration of back pain was 3 days. What is the most probable diagnosis? How would you manage this patient? Do I have any volunteers? Right. So in the absence of volunteer, it's a mechanical back pain due to muscle spasm from heavy lifting. Oral analgesics and proton pump inhibitors were administered. After 1 hour, the ETU is still at significant pain, was administered an injection ketorolac intramuscular and a tablet tizanidine, a muscle relaxant, and he improved. The next is an interesting case. A 45-year-old male with low back pain, with bilateral leg weakness, saddle anesthesia, and urinary incontinence since this morning. The MRI shows a L2, L3, a large disc prolapse with compression at that level. Any volunteers for what the diagnosis is? Sorry? Excellent, excellent. Right, thank you. Thank you. I'm unable, because I have the presentation going, I'm not able to see the name of the person. So excellent. So this is a cauda equina. I'm glad that you answered it. So what is the management for cauda equina?
Immediate
Can we just try conservative therapy?
No.
Surgery.
Excellent. Thank you. So patient was diagnosed with an L2, L3 disc prolapse causing a cauda equina syndrome, underwent a successful discectomy, and went on to have successful recovery over the next 1 week. And I must tell you with this particular case that it is imperative that you try and operate. It's an orthopedic emergency and it must be operated on preferably within 24 or 48 hours. The delay in diagnosis, delay in treatment leads to prolonged recovery. And it's not fun having an incontinent bladder and bowel, trust me. Okay, so it's important that you diagnose these patients and send them to the correct person for appropriate surgical intervention. Third case now. A 68-year-old female with a history of fall 6 months back and improved following osteoporosis management. So what I have failed to mention was she had normal neurology following the fall, and she was just put on some alendronate 70 milligram a week and also on vitamin D, and she subsequently improved. Recently developed weakness and numbness over the leg over the last 1 month. How would you approach this patient? This is the X-ray that I put on the screen. Any volunteers for this? Can you, I mean, it's not the clearest X-ray, but you can make out something, I believe. Can somebody tell me where is there a fracture and what level it is? Can you make out? Any volunteers?
Wedge fracture at L1 level.
Excellent. Okay, so you can see a wedge fracture at L1 level. It actually looks healed and it looks old. So I congratulate the person who answered. Excellent answer, right? Okay. Now, because this lady developed a neurological deficit, we decided to do an MRI scan. I bring that up on the next slide. Now, so on the left, you see the MRI scan. So would somebody else try to comment on what they see on the MRI? So the L1 fracture is confirmed. Is there any compression to the spinal cord or the cord equine at that level? Any comments? Any another person would volunteer? Now my cursor is on a normal non-compressed level where you can see the CSF, which is white, and the nerve fibrils are there, and you see this thing. Whereas at the level of the fracture, are you able to make out that the spinal cord is pretty squashed? Is that visible? Can you all see my cursor?
Yeah, we can see the cursor.
Right. Okay. So then there you see there is some compression of the cord at that level. So we realized that she had a malunited or a non-united fracture at that level causing cord compression. And because of the cord compression, she required surgery. And then this is what was done to her. So because it was a thoracolumbar junction, it's imperative that a 2-level fixation is required. So she had 2 screws above, 2 screws below, and the fracture site was bone grafted. You can see the bone graft inside, and the fracture, the broken bone was brought back to its original contour by impaction bone grafting and destruction using the screw construct, and her neurology progressively improved. So I won't bore you with any more cases. So what is the key take-home messages? Most low back pain cases are mechanical and self-limiting. So all you need is reassurance, avoid unnecessary imaging. Red flag signs require urgent evaluation. You must include a minimum X-ray or even an MRI scan. Early activity and rehabilitation prevent chronicity of low back pain. Multimodal approach is essential for chronic cases. Refer for surgery when conservative management fails. And do not forget the cauda equina. Thank you very much.
Thank you, Dr. Jana. That was a very interesting talk, a very useful presentation. So can I open the floor now for any questions that you all may have for Dr. Jana, please? Please just unmute yourself and you can ask.
Sure. Thank you, Dr. Jeyakumar, for the informative session. I just would like to get your thoughts on when dealing with a patient with chronic back pain. What are your thoughts on the belt that we use? One is because sometimes we advise them to use a belt to help them, whether it actually results in symptomatic relief. And then what type of advice should we give them in terms of their the area where they sleep? So the bed, sometimes they say use a hard board under the mattress to give it a bit of extra support. I would like to get your expert thoughts on those. Thank you.
Yeah, so basically the lumbar corset or a thoracolumbar corset is a device that can be used in the acute setting when somebody's got a severe backache, either due to a muscle spasm, a disc prolapse, or even a healing fracture. Some of the fractures, because of time constraints, lack of theatre availability, we manage conservatively. For the acute episodes, yes, the lumbar corset will work, but it's not something that you wear lifelong. You must strengthen the core muscles, axial muscles, and then over time you maintain the erect posture that is required by your own muscle strength. The same thing goes with the neck collar, which is akin to the lumbar corset for the lumbar spine. The collar is for the neck. So yes, in the acute stage, yes, but not for years and years and years. That's the first question. Second one, what sort of mattress or what sort of position do you sleep in? Yes, it should be a firm to a hard mattress where it doesn't sort of slouch in over the years. Yes, some orthopedic surgeons recommend a hard board with a small mattress where it doesn't slouch in. There are various fancy orthopedic mattresses, not necessarily all of them work. So something that is not too springy, that doesn't slouch in too much, is what is recommended. And I, of course, would tell my patient generally not to have a large pillow, because then when your neck is in flexion during the night sleep, that also aggravates your pain. So it should be a fairly firm to hard mattress, and you try to sleep supine if possible. Does that answer the question?
Yes, thank you.
There's a question on the chat by Dr. Sendil Kumar. He has
Yes.
asked, is TB spine a radiological diagnosis?
It's actually a TB spine is diagnosed in a multimodal way. Firstly, I would say it's a clinical diagnosis because at the end of the day, it's the patient that you treat and not the radiology, not the MRI or the X-ray. Of course, we assess, we confirm the diagnosis by doing an MRI scan. So yes, we also these days generally take a biopsy because sometimes the MRIs have been reported as tuberculosis, have showed up sometimes a fungal pathology, or very rarely some other bacterial infection also. So for that reason, if there is the slightest doubt, we also tend to do a TB culture by a CT guided transpedicular biopsy and or TB culture as well as fungal and histological examination. So it's clinical, histological, radiological diagnosis would be my answer. And of course, the treatment is anti-TB. The treatment of choice is non-operative, and it is anti-TB treatment from the chest clinic, the MRI. And with 12 months to 18 months of anti-TB treatment, TB can be completely cured from the spine without significant sequelae.
Thank you. Can I also just ask you, when we have mechanical back pain, in terms of exercises, what sort of exercises can we as GPs start off with routinely? Or are there websites and all that we can refer them to for them to have a look and work from?
Yes. Okay. So basically, the American College of Physiotherapy have certain exercises where you can that's available on the website. So a lot of these things. Or what I would suggest is, if somebody comes to you as with back pain, it will be safe to refer them to a physiotherapist, because I think that's not the time for somebody to look at a YouTube video or a video and then start doing it. So I think it should be done after, like from a proper physiotherapist, and then you can do core strengthening exercises and maybe facet joint, sacroiliac mobilization exercises, and that is the safe thing at that particular time. Because if you just ask them to follow a video, not everybody's got the knack to do that. So I think sometimes there's a risk of things being aggravated as well. So that is why I wouldn't recommend that. But under supervision, yes. And it's not as if you have to visit the physio every day. You visit the physio, you learn how to do it, and then you practice it. I always tell my patients, 10 times, 10 sets, every hour you're on the bed, you do it. Right? It's not a question of getting the physio down. So, doctor, can I call the physio 3 times, getting down 3 times a day or 5 times? No, that's not how it works. You do it under his supervision a couple of times. You know that you got it right. You're not going to do it wrong. And you know what you can do, what you can't do. And then you just have to do it over and over again, and then you get better.
Yeah, thank you. There is a question on the chat. It says, this is Dr. Tharaka Alvis. So can you please briefly outline the management of a common situation, sacroiliitis?
Yeah, so sacroiliitis is generally due to degeneration. It's non-infective, and most of the time it can, how do you diagnose it? Basically, the patient complains of back pain lower down, either on the right or left. Generally, it's only one side. And this pain doesn't usually radiate, but it's very excruciating. And if you can do a cross-body adduction test where one leg is kept straight, if you can follow, if you're with me, the other cross over to the opposite side. And that is what is called a sacroiliac joint distraction test. It is when you do that, if you can palpate or press on the sacroiliac joint, there's significant tenderness at the same time. So that kind of clinches the diagnosis. You can put the patient prone, and then if you palpate on the sacroiliac joint, which is a palpable structure, you can elicit the difference between the non-painful or the non-inflamed side and the inflamed side. So once you confirm the diagnosis, I generally would do a baseline X-ray and a ESR and CRP, simply because sometimes you do get really infective case of sacroiliitis as well. Sometimes it's part and parcel of an ankylosing spondylitis also. So you might see a bamboo spine and other things as well. In that case, you'll have to start the treatment for that as well. Most of the time, it's not just pain relief, a lumbar corset, and physiotherapy, mobilization of the sacroiliac joint, where you can bend your knee and hip to 90 degrees, drop the knee and leg to either side, lift your bottom, squeeze the bottom down to a pelvic thrust, 10 times, 10 sets. Over time, gradually it improves. The most important thing is not to put strain. So when you get off the bed, you should ask the patient to roll over to one side, support himself with an arm, and then get up. So if you follow these basic things, then this thing. But make sure that you have these infective cases in the back of your mind, because only then when you see one, you'll pick one up. Otherwise you think all of it is just degenerative.
I have one more question. So sorry, you were saying, we need to, in the history, clearly, like sometimes back pain may be related to the hip, or the vice versa. Hip pathology may present with back pain, etc. So in the history, are there specific questions that you'd want us to ask to sort of nail down whether it's more likely to be a hip pathology?
Yeah. The first thing in the hip problem is, can you sit on a chair with your leg crossed over? So generally, the back is eliminated from this. So if you can sit cross-legged on a chair, put a sock on or to alternative legs, that means your hip can externally rotate fully, right? So if you are with me, yes. So if you're seated on a chair, you need to put a socks on. So you're not going to bend down to the socks to put it to your foot. You're going to take your right ankle, put it on your left knee, and then going to put a socks on. So if you do that, that means your hip has got near normal external rotation. So that pretty much seals the fact that your hip is all right. Second thing is, if you can climb up and down stairs, if you can do a half squat, then definitely your hips are all right.
Do we have any more questions for Dr. Jana? Okay. I think there was a very clear presentation, Dr. Jana. Thank you. I think that was extremely useful. So thank you for the talk today, and thanks everyone for taking the time to join us this Sunday evening. And we hope that we will see you all again next month at our next CME webinar. Thank you, Dr. Jana.
Thank you very much to the College of General Practitioners. I would thank the entire college, and I would leave on this note. I'm currently the secretary of the Sri Lanka Orthopaedic Association. Our annual congress will be on the November 6th, 7th, and 8th at Cinnamon Life. We would have numerous presentations by experts who are far more from other countries as well, who are far more advanced in recent knowledge as well. So I will send the flyer across to Dr. Kalla, and if I just wish you a warm welcome to our annual congress as well. There are so many things that the College of General Practitioners could take away from our congress. So I would like to give you a warm invite to that. It will be November 6th, 7th, and 8th at Cinnamon Life. And we will send you the details through Dr. Kalla. Thank you so much to the College of General Practitioners and to Dr. Kalla. Thank you so much.
Thank you. Thank you very much.